And I have involved in teaching UG and PG, and I had a very good feedback from them all. And most of them are doing well in their life, and that's something what we take as a reward. Dr. Garima is one of them who had finished her PG in KD Dental College, Mathura. So I'll start with saying that the oral mucosa itself, such a versatile organ, part of the integumentary system, part of the aerodigestive tract, and it's a specialized mucosa, especially because we have a specialized function of taste by the tongue. It's the mirror of multiple systemic diseases. Systemic health you can make out by looking at the texture and color, etc., of the oral mucosa. It's comprising of the epithelium and the layers, the connective tissue. So the color and texture gives you whether it is healthy or not. But what we need to remember is that the oral mucosa just does not exist by itself. The entire teeth, the alveolar bone, tongue, saliva, gingival clavicular fluid, which contains immunoglobulins, and the various commensals which are there, the good bacteria of the mouth. So you know the histology of this, and then when there is a reaction or when there is a hypoplastic growth, when there is something which has gone wrong with epithelium, it all shows into the mouth in various forms of healthy or unhealthy patterns. So it is a mirror of general health. It is a mirror of systemic pathology. Any systemic disorder, either by radiographic or clinical manifestations, can be identified by a thorough examination of the mouth and the head and neck region. Multitude of diseases are there, so multitude of presentations are there. Many of them will be confusing for a novice in practice. Now, it should be as good as this every time when you say a healthy mucosa, a label mucosa should so look as in the textbooks they say rosy pink. Our ethnic variety does not have a healthy rosy pink. We should have a healthy mucosa like this, and examination of this mucosa has to be done by reflecting like this, so that you can see the labial surface, the lingual surface, the gingival surface clearly, and the buccal mucosa, the commissure area, and retromolar area should be examined for every patient. The palate, the uvula, and dorsum of the tongue, where the entire papillae are there. And on the sides, you have on the dorsum you have the keratinized filiform papillae, which are the plenty, and in the anterior region you have these filiform papillae, fungiform papillae, and then on the lateral side you have very few number of foliate papillae. Undersurface of the tongue, of course, the varicosities can be seen. Otherwise, you have the micro openings of the minor salivary gland ductules, and you have in the floor of the mouth we have the submandibular duct opening. Palate should be with a clear rugae without any inflammation of the salivary glands. And healthy mucosa should look like this. But when you see healthy mucosa, if you find something like this, these are Fordyce's spots. These are sebaceous glands, heterotropic sebaceous glands which are present. Am I audible? Am I audible?
Yes, sir. You're audible, sir.
And people are with me, right?
Yes,
all
sir.
of
Yes.
them.
Everybody says.
If there's anything that in between, if you require to stop me or ask something to be re-shown, please tell me. Okay?
Absolutely, sir. Absolutely. Okay, sir. Thank you.
थोड़ा फास्ट जाऊंगा, ये नॉर्मल सब आप सबको पता है.
Right, sir.
And now you see in this tongue, you can make out that there is a small area of depapillation in the central portion. There is a hairy tongue appearance or a colored filiform papillae. Most of the time, this is candidiasis which occurs, and it is called as the rhomboid glossitis type. Okay, so when you have healthy mucosa and healthy tongue, it's clearly visible. And if you have stained or infected tongue, you have multiple colors like this on that. So hairy tongue is one description that is given to it. This is basically because we are not keeping the mouth clean. It's basically bacterial stains which causes the growth of the filiform papillae and also bacterial infection on top of that. When you have a small swelling like this on the right side, if the slides are clear, I'm sure you can appreciate on the right side of the ventral surface, there seems to be a small globular swelling. It is nothing else but a salivary gland accumulation wherein you have a ductal stenosis or a ductal rupture, and which can cause a ranular appearance. Ranula, which is collection of salivary. What we need to look at is when a patient presents with abnormalities like this. Now, if you look at this, it's a small deciduous tooth which is there in the E area and a very gross looking ulceration there. Now, what is the reason why it should actually happen here? If at all we look at a patient who is an adult, who is a habitual, or somebody who is a grown, an adult with a non-healing ulcer like this, we should be actually thinking in terms of dysplasia and malignancy, etc. But when it occurs in a small child like this, we should actually take a proper history here. And then there is a habit which is called as masochism, also called self-inflicted injuries. Certain children who are abused or certain children who are battered syndromes, etc., they develop this self-inflicted injury. Can you believe that this is one injury caused by a toothbrush itself? That patient has been continuously inflicting injuries to get over his mental block. One rare area where you get a lipoma. Can you see that small yellow colored small swelling which is there in the floor of the mouth region? On the right side of the screen, you can see that small yellow area. This is not a very common sight for a lipoma. Lipomas occur in the mouth, especially only in the buccal mucosa where there is a pad of fat. So one rare thing like this can occur. It's a benign tumor. It's a very soft tumor. It can be totally excised in toto by either laser today or by the blade itself. Podaceous granules can sometimes look like big lesions in the buccal mucosa. So you should be aware that this can be occurring. Just above that, you can see a plain line, a hyperkeratotic line, which is the occlusal line. When you have a buccal mucosa where there is interspersed white lesion, areas of erosion, wrinkled appearance, tobacco user, or sharp cusps of the upper teeth like this, the melanin part, the melanoma just look where the pigmentation is there more, those are healed areas. Those areas where there is erosion are the ones which are instituted by the sharp cusps of the upper teeth. And if this guy is a smoker, then you have to make sure that it has to be biopsied for dysplastic changes. Okay. Now, when melanization like that, I told it was part of healing. But when there is widespread melanosis with real dark black color, then you are in for trouble. We know that this is something which is more dangerous than just melanization. This is a malignant melanoma. Malignant melanomas, whatever they appear on the surface mucosa, it is too less presentation than actually what would have happened inside. Take a radiograph here, you will find that the entire bone might have been resolved by this time. So malignant melanomas are not difficult to diagnose, but by the time this melanosis, the so-called hypermelanotic areas appear, the destruction would have happened. And not only that, this is very highly metastasizing to the internal organs. That is one issue with malignant melanomas. If they're clearly presenting like this, no issue to diagnose. But look at this premolar area, first premolar. Can you just see above the attached gingiva, there's a small faint shade of pigmentation. Now, this is a amelanotic variety of melanoma. Amelanotic in the sense it doesn't produce melanin to the extent, but it is as dangerous and as malignant as the other variety of malignant melanoma. So your observation in patients who are just complaining of a numbness in that area, you have to take a radiograph there and then make sure that it is not something benign. It is a malignant melanoma, the amelanotic variety. Are you able to appreciate this in the slide there? This patient had actually come with just a sensation of numbness, paresthesia, that's all. So when we observe it very carefully, even though it was not as fiery as the earlier malignant melanoma slide, this should be identified by a clinician. Lingual varicosities, varicose veins, as age progresses under the surface of the tongue, there is nothing much that we need to do unless there is a hematoma formation or an injury which happens there. Otherwise, it should be a normal variation. Very commonly, you will see that wherever there is a trauma on the buccal mucosa or the labial mucosa, if there is a traumatizing tooth there, the minor salivary glands can present with minor mucoceles like this. So these are again very easily treatable in your dental clinic. If you have a laser equipment, much easier to treat without any pain or bleeding. Now we saw one hairy tongue earlier. Now this has got hairy tongue appearance, but on the right side of the slide, if you see, there's a lot of keratotic enlargement there on the filiform papilla area. Now these are again telling you that there is something growing there. It is not just a variation, or it's not just a bacterial infection. Here it seems to be a proliferation which is seen there. That again should ring alarm bells in you, and then you need to actually get a biopsy done and look for dysplastic changes. Multiple causes are there for bleeding gums. When you have clean teeth and then still there is a linear gingival erythema like this is a classical picture of either linear immunoglobulin related gingivitis or a patient of AIDS. Linear gingival erythema. Even if they keep the teeth as much clean as possible, of course, there are areas where there is plaque accumulation here. Other than that, you should be looking at even after you do a thorough oral prophylaxis, if that remains, you need to actually go in for a blood test. Gingival bleeding along with gingival enlargement with combined inflammation along with that. Now, inflammatory gingival enlargement are not that difficult to treat because they will go once the local factors are removed. And maybe you will end up in doing a little bit of gingivectomy later. Whereas if it's a drug-induced growth, it will be more fibrous. It will be more fibrous and less inflammatory. The inflammation will be restricted only to the areas where the patient is not maintaining the hygiene. So inflammatory enlargements like this will require later, you will have to go in for the drug-induced enlargement, like anti-epileptic drugs, oral antidiabetics, especially the oral antihypertensive drugs, especially the calcium channel blockers. They do cause such kind of enlargements. A small localized enlargement in a pregnant patient, you know that it is just a hormonal variation and it will go by itself once the bundle of joy is delivered. So pregnancy tumors need not be treated. The only thing that we need to take care is that it has to be given with a good antiseptic mouthwash so that it does not grow into a bigger one. Similar type of enlargements can be also a sign of blood cancer. Now, leukemia, when you see that there is enlargement like this, it is not because of plaque, it is not because of anything else. These are basically the leukemic cells which are infiltrated to the gums. Take a biopsy, you will see not gingival epithelium there, you will see leukemic cells infiltrated in that. So, although there are other symptoms and signs which we need to rule out, you have to look for the purpuric spots, you need to see whether there are areas of petechia in the hands and legs, etc. Along with that, if there is gingival enlargement like this, always go in for a blood checkup. Peripheral smear is a must for, even if it's a local gingival enlargement. I would advocate that as a protocol, go in for a blood examination, go in for a peripheral blood smear in any case of gingival enlargement. This is an acute myeloid leukemia. See the enlargement. You can mistake it for routine enlargement, which is either drug induced or due to inflammatory and or fibrotic enlargement in a bowel breather. So all these, we need to know that this could be a possibility. So that's why I said it's better that we need to go in for a blood test, especially when you have a localized or a generalized gingival enlargement. Now, if you look here, fiery red mucosa, especially in the attached gingiva and the free gingival margins, even if the patient undergoes a prophylaxis, this remains. There are no white components here. There are more of fiery red appearance. It doesn't bleed. This is typical of mucous membrane pemphigoid, benign mucous membrane pemphigoid. We can treat this. There's no issue at all. That can be treated by local therapy itself. Whereas such blisters, when there is encrustations, when there is bleeding, when there is peeling of the entire mucosa, initially with some amount of vesicle formation, that's a sign of an oral pemphigus. Even if there is no dermatological lesions, it could be just existing as an oral pemphigus. Similarly, lichen planus is another disease where you will find typical striations, very minuscule striations in the mouth in this case. But if you look at the patient, examine them properly, you will find that there are whitish, purplish hue lesions which are there on the arms and the feet, etc. It can be much more gross like this in another patient, wherein it's actually thickened and keratinized. It's not just pruritus or it's not just whitish keratotic areas. You know that typical Wickham's striae are formed there. but they can actually accumulate into big carotenoid accumulations. So you need to actually do a proper examination, even though directly you don't go jump into the mouth. Instead of that, at least examine the feet extremities of the patients for any changes in the skin, etc. Now, lichen planus can be treated by routine oral steroids are the mainstay. And if there are no other local factors or systemic factors associated, like an antihypertensive drug or any other drug which is there, we may have to modify with the physician's consent the type of drugs that they're taking. So in these cases, it could be presenting in the mouth with various presentations. Now, if you look at the anterior portion, it's reticular lichen planus. If you look at the posterior portion of the right buccal mucosa there, it's eroded already. But it can be treated. It can be treated by routine judicial use of steroid without pulse therapy all the time. Now, mucous membrane pemphigoid again, this will disappear very, very, very difficult. It will go, but it will take some time, at least 3 to 4 months of time of proper medication is required for these kind of lesions. Why I am showing these slides is because not to say that we have treated them. I want you to identify these things in your clinical practice. Now, why do you say that this is lichen planus? Now, if you look at carefully, you can see that there are whitish striations along with the mucosal peeling off. The erosions and the whitish striations all over the mouth are the ones which suggest you that it is a lichen lesion. Now, unless you don't find those whitish striations, you cannot call it a lichen planus clinically. Erosive lichen planus again can occur either in the mucosa or in the tongue area. It can be causing atrophy of the entire tongue. It can cause keratosis like this. It can cause typical erosions, and they are very resistant to routine treatment. One lesion which you can confuse with lichen planus is lupus erythematosus, the so-called butterfly rashes, which is there. Systemic lupus erythematosus, when it is there, you can find similar whitish striations and also the erosions similar to lichen planus. So we need to actually have a differential diagnosis there. Erythroplakias are much easier to diagnose because they have the typical velvety yellowish, and these are mostly in situ carcinomas. By this time, when they present with a lesion like this, you know that they are tobacco associated lesions, plus they will have carcinoma in situ or invasive carcinoma by the time they present like that. It's nice to see these small kiosks everywhere. These guys are actually toxic vendors. We say that because not only cigarettes, but a lot of chewing tobacco and chewing things. Khai ke pan Banaras wala is fine as far as you take only the Banarsi pan, wherein you are not actually adding tobacco and arecanut into that. Otherwise, the basic carcinogenic cocktail is produced by the addition of the lime with the slated lime with tobacco and with the supari. Those are the two components which are the ones which. Otherwise, if you really look at how in the ancient times in Ayurveda or in Ashtanga Hridaya, they have said Tambula Shastra. Tambula is the pan. Tambula Shastra never had the ingredient wherein the wife, when the husband comes back home and he takes a bath and he has a good meal in the night, and then she will give a small tambula. Tambula is the pan. In that, they never had mentioned the tobacco or arecanut in that. They had spices in that, they had clove, they had elaichi, they had things wherein the mouth can actually be freshened and it can increase the digestion. Whereas today we know it can cause just by zarda and gudka itself, it can lead to a real crippling disease wherein your entire mouth mucosal elasticity is lost and progressive fibrosis. And it's a conditioning the entire mucosa wherein a pre-malignant condition can occur or a carcinoma can develop by itself. And more importantly, even though it does not transform into malignancy as much as leukoplakias or erosive lesions, this can be a crippling disease where the patient cannot open the mouth. Even surgical treatment, fibronectomy, or if you do the grafting by taking a buccal mucosal flap, etc., most of the times it fails because the induction of fibrosis does not stop once it starts. So that's why submucous fibrosis should be noticed. Now, any white lesion need not start like a hyperkeratotic one, which is like a plaque. Initially, this filmy area, small thin film area, this you should not miss your diagnosis here. That's why I put that typical feature there. Always look for galvanic factors wherein you have multiple amalgam restorations or different types of old and new restorations, etc., that can contribute to the white lesion there. The initial wrinkled appearance of a submucous fibrosis. Initially, there's just this corrugated, wrinkled appearance. You should not miss this part, whether there's burning sensation or not. Even if it's a small angular area where you have a small keratotic patch there, initially maybe you will try with lycopene and your chemotherapeutic agents. But here, obviously, there is a galvanic part also. You need to do the dental treatment along with the treatment of this mucosa, change these crowns, and then make sure that the mouth does not have anything metallic afterwards. And then I'm sure this kind of a lesion will heal. So healing is not difficult in such kind of lesions. Angular area, again, please make sure that sharp cusps are rounded off in the dental clinic, and make sure that the patient does not get into habits and he's reversed from the habit. Occlusal lines can look very gross, and it can look like as if it's a disease there, but then this you need to actually identify that it's just a buccal or buccal keratotic line or a normal variation there. When you have a palate presentation where there is parched keratosis along with multiple areas as if it's a dried up desert look, and along with that, the salivary glands are slightly inflamed, the ductal areas are inflamed. This calls for routine palatine stomatitis is not a disease where you have to be really bothered about. Most of these are associated with smoking habit or reverse smoking habit. And then if they produce this enlargement there, then it calls for you to be a much more careful, not just reversal of habit. Here, you need to actually take a biopsy and make sure that it is not dysplastic to the level. Similarly, here, the palatine the salivary gland ductals are not just inflamed and reddish spots, but they are enlarged and coming out as a hyperplastic tissue. These are dangerous signs in palatine stomatitis patients. Parched leukoplegic patches. Now, all these are better treated by a wide excisional biopsy rather than doing any local application. When you see something like this, just go in for a nice laser guided or laser used or assisted or a scalpel biopsy, and then make sure that it is excised it with a good amount of normal mucosa around the lesion. You can do that, and then now you look at this tongue here. Lateral surface and the ventral portion is involved. This guy is absolutely a teetotaler. He doesn't drink, he doesn't smoke, he's only habituated to tea. This is a typical presentation of a viral induced oncogenetic lesion. So proliferative verrucous leukoplakia or PVL. These are much difficult to treat because they are viral origination. So there is no habits here. It's a leukoplakia, but it's verrucous leukoplakia, the typical verrucal component you can make out in the presentation there. So proliferative verrucous leukoplakia should be treated like a early invasive carcinoma. The depth and the surrounding tissue that has to be removed has to be determined there. Today, with lasers, it's much easier to remove these. Now, when you have candidiasis or oral thrush, we know that it's multiple white curd-like patches which are pseudomembranous and that can be easily taken off. When it comes in as a part of oral manifestation of AIDS, these are not easily removable. They will get stuck onto the mucosa. They will have a typical presentation where the entire so-called curd-like patches are there, but they are not easily removable in case of AIDS patients. This is a typical hallmark hairy leukoplakia on the tongue lateral border. If you see from that premolar area onwards, if you see, there are whitish corrugated areas. This is again Epstein-Barr virus induced hairy leukoplakia, no habits required. Here it's a hallmark lesion of oral manifestations of AIDS. When it's just leukedema like this, you don't have to bother. It is just a cloudy white appearance. You stretch the mucosa, that cloudiness goes, and then it comes back when you relieve the mucosa. You stop the habit in the patient, this will also disappear. Filmy leukoplakias above restorations. If you see the similar features on the buccal mucosa also, these are again white lesions which we need not be immediately taking the knife and cutting it off. This can be used by chemopreventive agents. But when there is a traumatic enlargement like this with a verrucous component, this obviously seems to be a trauma which is arising from the sharp cusps, and then it's caused a fibrous enlargement. Many times it will be pedunculated. It's a routine traumatic fibroma. The patient will not even complain of pain in such cases. An extraction of one of the tooth will actually prompt this kind of a traumatic fibroma. Now, look at carefully this lesion which is there on the palate. Here also there is a verrucous component, but if you take a lens and look at, zoom it there, you will find small finger-like projections, which are papillary projections. This is a typical picture of a papilloma. It's a benign papilloma lesion, epithelial papilloma lesion, amenable to just a wide excisional biopsy. That's it, that you do it. They may recur. When you are a denture wearer and if the denture is not proper, they can actually come to you and say, doctor, this denture is loosened up and I'm actually getting a lot of pain and ulceration in the mouth. So denture, which is causing fissures in that, here of course the denture has to be changed or the denture has to be trimmed and to relieve it. It can be very gross looking like this when they are a denture wearer. If the denture is not proper, it can grow around the denture like this in the flanges areas. There's a quiz for all the doctors who are sitting there. I'm sure all of them know it. You don't get it because you are gloved all the time. If you're not gloved, and then if you're looking at a patient with a viral lesion, especially herpes lesion, this is herpetic whitlow on the fingers. But nowadays, we don't get it because we are always using barrier protection. Tongue can present very grotesque like this. It's just a fissured tongue. The only thing that you need to do here is make sure that the hygiene is maintained. Ask the patient to take some mouthwash, especially in the night before they sleep. Clean up these gutters which are there on the tongue. Now, if you see on the posterior portion of the tongue on the right side, there is a small enlargement which is seen exactly. This is at the site of the foliate papilla. This is a rare condition called as foliate papillitis, wherein the foliate papilla alone enlarges. Patient will not have any much of pain or anything like that, but fungal infection superseded with this can actually cause foliate papillitis. So one of the things that you notice. So the idea of showing various aspects of the mouth is to make sure that any dental surgeon who's practicing might as well take the mirror and make sure that you examine the entire mucosal parts of the tongue. This kind of enlargement, when it occurs, now if you see, this patient has been given some huge bridge, a long span bridge, like Pamban Bridge down south in Rameshwaram. This kind of a bridge, and if it's not fitting properly, and if there is infection between that, you see the amount of enlargement that has occurred there. So here, how much ever gingival therapy you do, it will recur unless you make sure that the denture or the so-called fixed partial denture is corrected. Now we saw proliferative verrucous leukoplakia. Now this is the typical presentation of a chronic, long-standing verrucous carcinoma itself. Now this carcinoma does not metastasize like our typical squamous cell carcinoma. This verrucous proliferation will be more superficial in the layers of epithelium with very minimal amount of metastasis. But the picture will be chronic lesion. Chronic. It will be 7 years, 8 years. I have this lesion. I have no problem. I've got no pain at all. Only thing is it's a little whitish in color. That will be the presentation that they give. So this can be treated and it's got much better prognosis than squamous cell carcinomas which metastasize. Fissured tongue, another type of fissured tongue. Another rare site of a small lipoma which has occurred in the palate here. I had shown you one in the floor of the mouth. When you have lesions like this, they say there is no pain at all. It had actually caused an injury earlier, then I'm continuing with my habits. But if you palpate this, you will know that there is indurated borders. Induration is the thickening of the borders of the ulcer. The floor will be not movable. It will be attached to the face. So these are initial signs of a carcinomatous ulcer. Whereas these are typical ulcers caused due to either a viral infection or due to a recurrent after stomatitis. This on the label mucosa, what you see there is a typical ulcer with a good inflammatory halo around it. This is self-limiting unless there is a systemic connotation. Now, recurrent aphthous ulcers are not fixed to the base. They occur on the mobile mucosa, the movable mucosa, not in the palate or in the gingiva. When there are ragged borders all around with secondary infection, herpetic infections also can look like this. Herpetic vesicles which are broken and then they can present with an ulcer like that. If there is ulcer with slough like this, continuous chronic presentation, you know that it is going in for infection. If you remove the slough, and that slough itself can be there presented for a microbiological assessment of what type of antibiotics can be given. In chronic resistant ulcers like that, you can actually treat it better than routine antibiotic therapy. So sensitivity taken from any material what is available on an abscess or a ulcer should be done in 3 days. They can give you which antibiotic is sensitive. Again, another case where you can clearly make out the induration on the tongue, small ulcer, but on the tongue it's a dangerous ulcer because tongue has got venous decussations. There is crossover of the veins, crossover of the lymphatics that can actually cause spread of a carcinoma bilaterally. It's not only ipsilaterally that you will see that the nodes are affected in the tongue, especially the base of the tongue, more than the tip, the base of the tongue area. You will find because of the decussation of the lymphatic channels, you should also examine the opposing side cervical nodes in such cases. So traumatic ulcers can be presenting like this. This is again a toothbrush trauma, which is looking very grotesque. So a proper history there is very important. A typical mucosal presentation. Mucocele are most of the time seen in the lower label mucosa. If there is a canine which is projecting out or a lateral inferior upper which is projecting out. And this mucocele here, it does not have the transparency because it's become chronic. So they will become fibromucoceles after some time. Those fibromucoceles require good surgical excision and then correction of the offending tooth. This should not be mistaken for anything. It's just the parotid papilla. The healthy parotid papilla, you need to actually take a small piece of cotton, go to that second molar area, stenson duct opening, and milk the gland. And see a small, nice drop of saliva comes out of it. That's a healthy parotid duct. Again, this kind of appearance in the base of the tongue or so-called posterior one-third of the tongue. These are normal appearance of lymphoid follicles. Some patients will present with a slightly hypoplastic lymphoid follicles like this. The circumvallate papillae and the lymphoid follicles can look like as if there is a proliferation. They are not proliferation. If you really carefully look at every patient, you will find that there are places like this in the posterior one-third. When you find a geographical pattern of denudation or depapillation, which is with or without symptoms, with symptoms it will be candida, otherwise it will not be required to treat. Just cancerophobia has to be removed from the patient. Patients will think, what is happening to my tongue? Today it was here, the other day it was there. So it's a migratory glossitis, which is just a candidal infection most of the times. But when there is denudation totally of the entire dorsum, we know that it is atrophic glossitis, atrophy of the entire filiform papillae and the fungiform papillae, and a very bald appearance of the tongue. So iron deficiency anemia is the commonest cause of that bald tongue, unless they have undergone some radiation therapy or if the patient is severely diabetic. Diabetes also can cause atrophy of the papilla. If it is folic acid or typical vitamin B complex deficiency, this is the typical beefy red tongue, as if it's the red meat which is there. Similar presentation will be given with amount of inflammation. That type of atrophic glossitis is caused due to folic acid deficiency. Pernicious anemia, it looks like this. So vitamin B is one of the factors which we always take note of when you look at the tongue. But when the entire mucosa is red, it is also atrophic. This could be caused due to either an allergic reaction or due to an immune reaction. It could be also part of anemic stomatitis, unless it is a case of post-chemotherapy or a radiation therapy. I told you the various causes already: allergy, chemotherapy, radiotherapy, or deficiency anemias which are progressed. They all can cause stomatitis all round or widespread like this. Such cases, we need to actually boost up. Many times, a transfusion may be required in such patients where the hemoglobin is very less. Now, here, of course, there is a lesion which is very strange. Only in that area, this patient comes and complains. It's a lady. Uh, she was recently married. Of course, this is a abnormal sexual activity wherein they have used the mouth for their sexual pleasure, and that has caused this typical kind of lesion there. But when you see purpurae or petechiae in the palate and the soft palate area, always go for a blood picture. And I told you earlier, a peripheral smear is something which is very, very vital there. If there is anything which is related to blood related malignancy or platelet disorders, we can actually see by looking at the blood picture there. So it's always better to do a blood picture in cases wherever there is petechial or purpuric spots available in the mouth. Typical pseudomembranous candidiasis. I showed you that one again. This was a case of AIDS. This patient, of course, we lost within a week's time when he presented to us. Denture stomatitis, obvious cause is an ill-fitting denture. This is candida. It will go once you correct the denture and once you make sure that this antifungal therapy is given for these patients. Sometimes dentures, they add on things for suction for the upper dentures, and that can cause a traumatic injury to the palate like that. Exactly where the suction area is given for additional retention, that area corresponds to where candidal infection is there. Once you change this denture, it will be fine. Candida can also appear like this, just as a localized palatal lesion. So candidiasis can present with different widespread or localized areas of presentation. If you look at the tongue, there will be a corresponding lesion in here, something called as a kissing stomatitis or the kissing lesion it's called. The palate and the dorsal tongue will have candidal lesions in such cases. This, of course, you know what it is when there is a wild fire-like port wine stain, which is there entirely on one side of the face. The skin pigmentation and the oral mucosa will correspondingly have fiery red appearance. It's a congenital condition. You call this, I'm sure all of you all know about Stooge-Weber syndrome. Stooge-Weber syndrome, wherein you find this kind of lesions. Purpuric spots like what I told you this here. When you see this, you should be careful. They may not be caused due to local lesions. If there is trauma leading to local purpuric lesions like this, make sure that the blood picture is taken and rule out anything else that can cause that. When it's herpetic gingivostomatitis, palatal area will be one of the areas where it can be seen as a herpetic lesion. So they can be confusing. Here, always ask for prodromal symptoms. Whenever you suspect something viral, prodromal symptoms, fever, predecessing the formation of these vesicles, etc. A mild form of herpes labialis. Now, when there is a climate change, when there is some usage of a toothpaste change, or sometimes even patients who are just after coming after some hospitalization, etc., you will find herpes labialis. Again, this need not be treated by acyclovir or anything. You need to actually treat them by just giving a antiseptic ointment. It will be self-limiting unless the patient is on steroid therapy, severely diabetic, uncontrolled, or a patient is immunocompromised. Otherwise, these patients will heal. That will not be the case here. If you notice the multiple vesiculations which are there, widespread affecting both the mandibular, maxillary, and the ophthalmic area. This is zoster lesion. This is a reactivation of chickenpox virus. That if it occurs in an adult, you know that this guy is severely immunocompromised. This occurred in a patient who had been treated by a local dentist by steroids. Just because he saw that there are vesicles, he just asked them to take steroids, and that aggravated in this patient. And later, he turned out to be a patient with HIV positive. Now, look at the ulcer on the left side of your screen, that ulcer under the tongue. The obvious cause is here. He is not a tobacco user or he's not somebody who's doing anything with the teeth, but these teeth itself can cause sharp cusps of the teeth. They themselves, when they're resting on them, and once an ulcer forms there, it becomes a non-healing ulcer. And you know that when there is constant trauma in an ulcer and it indurates there, even that itself can, in the mouth, turn into malignancy, even if you do not have any tobacco habits. So always look for the offending teeth and the cusps and make sure that they are not there even if you excise the lesion. Okay, that is very important for us to note that even constant trauma or chronic trauma from anything which is sharp can also cause lesions like that. Now, this lady presented with something where she had done root canal treatment elsewhere. She had done a root canal treatment for the premolar tooth, and then one day she comes with a sinus opening. And when you look at the sinus opening inside, there is no pus formation. Instead of that, I could actually take out small pieces of small alveolar piece of bone. Necrosis was the actual symptom there. Then, when we took the history, she told us that during the irrigation process, I had severe pain, even though she was anesthetized. This is actually a sodium hypochlorite allergy to the patient, which has come out of the canal and then caused a huge area of necrosis. I had to actually go in for exploratory surgical debridement of this area, and then it healed only after that. So, in such cases where there is a sodium hypochlorite injury to the periapex, make sure that you don't seal the root canals, open the root canal treatment and keep it open for draining. And if it forms a sinus, make sure that a Neurobion tablet is given after the surgical debridement. Sorry. This kind of lesion, this patient was living with it for a long time. So after a lot of cajoling, he agreed to go in for a biopsy. Typical proliferative verrucous leukoplakia turned out to be a squamous cell carcinoma. So it's important that anything that is constantly present, even though it looks innocuous with no symptoms, get it biopsied and then make sure that the patient is treated earliest. Sorry, excuse me. Now see again another case of benign mucous membrane pemphigoid. Okay, benign mucous membrane pemphigoids can be grotesque looking, but they can be treated. What could this be on the tongue? There is nothing which can actually cause a lesion so specific like two lips on the tongue. Again, you should know what exactly the patient is wearing. The patient is wearing a appliance like this, and that has caused the tongue to go under that appliance. This is an orthodontic appliance which is given, but that has caused the previous lesion on the tongue. Don't get scared if there is pigmentation which is occurring. Pigmentation will be a part of healing. A part of healing. Every pigmentation is not melanomas. Pigmentation can occur along the salivary gland orifices also. This patient had come continuously to us saying that every day there is a bluish appearance on the tongue. The parents were really, there was a small carious lesion on the tooth which is next to the canine, and then, but we could not identify what exactly he was doing. He was denying everything, whatever we used to ask. It looks like as if some gentian violet has been applied. This is basically graphite, the pencil which is used, and he used to actually keep that as a habit, a parafunctional habit. He used to actually poke that upper tooth whenever there was pain, and the tongue was looking very different colored. Again, a trauma related mucocele on the lip. All right, so I'm just going to this. Look at here. He's got a nice mustache, but then he's got some hair growing inside the buccal mucosa also. This is not hair growth in the mucosa. It is actually a post-treatment case of submucous fibrosis, wherein they have taken a flap from the skin and kept the skin intact there. Once the graft is there, there will be some amount of hair growth till the time the mucosalization of the graft appears. So skin grafts can actually produce hair inside the mouth. Strawberry. Now, when there is a lesion like this is fibrous. Always, when there is a fibrous lesion, a tumor-like appearance, a growth-like appearance, always take a radiograph. Look whether there is calcifications inside that. Look how much amount of bone loss is there. If both are not there, we know that it's a very superficial lesion. If there is bone loss inside this, we know that it could be a tumor. A gingival fibroma, a localized gingival fibroma will look like this. It can be totally excised and There is nothing else to be done. But the differential diagnosis has to be like ossifying fibromas or patients who have got ossifying fibromas which are not peripheral but arising from the bone called as central ossifying fibromas. All right, so this just showed you just to say that everything which looks like a tumor need not be a tumor. Now, rarely we say always deciduous teeth do not produce, they do not remain till the time they produce a cyst or a tumor under the apex. This is one of the cases where they are presented with a small swelling, which is very characteristic, chronic, non-symptomatic, asymptomatic lesion. You take the radiograph, you can see that there is in the OPG, if you notice on the left side of your screen, that deciduous molar underneath there is a cystic lesion where the premolar is yet to come out. So that can also occur. It's not that every time you say periapical cyst is only occurring in adults. It can occur in a relation to a deciduous tooth also. The idea of telling that here is to identify that if there is a cystic lesion like this has to be treated like a cyst enucleation itself. You can't leave the epithelium there, even though it's a deciduous tooth and which is going to be exfoliated later. A severe case of cervicofacial actinomycosis. Nowadays, you don't get these kind of lesions so common. It is shown here because we need to know that severely diabetic, uncontrolled patients, uncontrolled diabetic patients, etc., the ray fungus can be a systemic lesion which can occur on the cervicofacial area. Now, this was one case where we had to actually enucleate a very big radicular cyst affecting 3 teeth. Now, when you surgically explore this entire area, what is your 2 options that you will do? You will have to do a root canal treatment, you will have to do a retrograde restoration, and then you will have to make sure that this cavity which is there, the entire cyst enucleated area, either it has to be filled with an allographic bone graft, or better, put something which is more feasible for bone growth of his own body to occur. I would always prefer the second one, wherein you take blood of the patient and centrifuge it and get the so-called PRP or PRF, especially fibrin. You get the fibrin, induce his own bone growth rather than putting anything foreign material, because foreign, any allograft which is placed can always have a rejection. So you take this nice gum-like, glue-like material which is centrifuged by his own blood, and platelets-rich fibrin can be packed into this area, and then it can be sutured. Within 3-4 months, you will see that the entire cavity is filled with his new bone formation. So medication will be given, calcium hydroxide can be given, and then it will induce formation of bone within 3 or 4 months, and then it can be a stable teeth for. What is his problem? I'm sure that entire audience will be saying, "Ye kya hai?" One side there are no wrinkles, one side the eyes cannot be closed as tightly as the other one side of the face seems to be dragged towards the other side. This is a typical unilateral facial palsy or a Bell's palsy. Now I treated him, and he was a saloon guy, and he was known to me also. Then he was treated by routine local steroid therapy, and then this guy came back later. This is the earlier symptoms where there is exactly no wrinkles on the left side forehead. Left side forehead, left side he cannot hold the cheek, by blowing. Later, of course, he was happy. He was a happy man once he was treated. And he had sent me the photographs. He was going to a pilgrimage in Sabrimala, so he was sporting the beard. Now see how he can close the eyes properly, and he can actually raise his eyebrows, etc. And frowning has occurred in both the sides of the foreheads. So treating like that, the patients are very satisfied, and most of the times when they go to other doctors and they refer it to you, you are also satisfied as an oral physician, not just a dental surgeon. Now look at this panoramic radiograph. The entire mandible looks like as if it's a flute. There's total burrowing of the entire bone, multilocular lesion, bilateral, thankfully benign. This lady had come as an accompanying person post-COVID to another patient. And then when she removed the mask, I said, there is something wrong with your lower jaw. Can I have a look at it? Go take a radiograph and come. And she came at the radiograph like this. This is a bilateral amyloblastoma, benign, And then we had to do nothing else, because if I applied any pressure, it would have broken. So it was in that stage before pathological fracture. So we treated it. I'll come to that part. This is the graft of covering of skin after we did the surgery. Then you see how the graft, skin graft, has typically given me space for my implants. See the gingival collar which is formed. Today, of course, we don't find that the skin graft is like this. We have got it entirely reepithelialized like mucosa itself. So we have given her the implants after the surgery. I'll tell you what surgery was done. If you see in this, you will find a small piece of bone over which there is a metallic structure, which is actually for the strength. And then you also see those multiple implants. There are 7 implants there. If you look at the posterior portion on both the sides, you'll see a lot of small radio opaque staples. That is microvascular surgical staples. We have anastomosed the fibula, which is taken from the leg, and we have incorporated that into the entire mandibular area. And then we have given dental implants on the leg bone. So that's cutting edge dentistry today, wherein you don't require any artificial things. You can harvest your own bone, which is amenable, and that can give her function in the mouth. That's the idea. After implant placement, it looks like that. The implants are there in position. Most of the skin epithelium has become oral mucosa in due course of time. This is entirely 1.5 years time that we did this patient's work. After placing the entire prosthesis, it looks like this in the radiograph. Okay, so I'm just telling you that routine dentistry or filling and a composite restoration or an aesthetic restoration or a smile designing or a root canaling or a disinfection is not just mere dentistry. When you do cases like this, and when the patient is aware that this can be done in a dental clinic, the surgery alone was done in the OT in a hospital. Otherwise, the entire things were done in the dental clinic to get her restore her dentition. Now, this man had sat in, it's actually the waiting area there, and he had come with severe unilateral trigeminal neuralgia. But once you treat a neuralgia, when you know that the things which can be given when in a case of chronic neuralgia, where he was treated by the neurologist there with routine carbamazepine, etc. We have tried something which is more efficient than that, and within 20 days of treatment, he came back with a proper smile. So it's possible that these kind of cases, the orofacial pain cases, will be treated in your dental clinic, provided you know how to treat them. Now, present day oral medicine and radiology, conventional oral medicine and radiology, you all have studied during your REG itself. But today, if you do not practice in your clinical dentistry without integration with the other specialists, then you are not up to the mark. You will have to have a team of expertise with all these specialists. It's very important that you have a team approach. And more today, cross infection control is much more important and significant, especially after the pandemics. And you need to know what exactly has to be done. This is not to show off with my car, it is basically for biomedical waste management. Another one, especially when you have your own clinic. You are working in a hospital setup, they will have their biomedical waste disposal. In your own clinic, you are in charge of that. You need not wear like a cosmonaut, but then basic barrier protection, mouth masks, head caps, your entire routine clothing has to be covered with a nice disposable gown. Have gloves properly. Make sure that you wear a eyewear, protective eyewear, especially when you're working. But this is India. हमारी कंट्री में एक्चुअली इस तरफ का डेंटल ट्रीटमेंट आज भी फुटपाथों में देख सकते हैं आप लोग. I'm sure you would have seen this happening in many of the northern villages. I have seen that. Even in Mathura, I have seen that. When I had first visited way back in 2002 in Mathura, I saw there were boards called as denturists, and these kind of guys were sitting down and doing quackery there. I'm sure India has developed much better than this stage today. See how when they took out Saddam Hussein from the tunnel where he was hiding, how the Americans are wearing just to take a swab for his DNA test, salivary swab. They're so well gloved and they are examining his mouth. No rocket science. You need to be digital today. If I'm using a scan for my patients who are going for an implant prosthesis, instead of subjecting him to a rubber-based impression or any other type of impressions, that's today's modern dentistry. You have to be digital. Use of lasers is nothing. Very easily you can just get trained in lasers. You need not be a big maxillofacial surgeon to do that. Small lesions, what is there in your purview, like a frenectomy or a laser biopsy excision or a mucosal excision like this, or the ones which I had shown you earlier where there is an ulcer treated, etc. And lasers, especially for biomodulation or biostimulation, soon after a SRP procedure, scaling and root planing, or a closed curettage cases, you can actually use the biomodulation ability of soft lasers. You are using TENS, then you are actually doing pain control for patients with chronic orofacial pain. Whether it's related to the TMJ or whether it's related to only muscular, then you need to actually use this. It gives you results than stuffing the patient with a lot of analgesics, which can cause acidity and other problems in gastritis, etc. So TENS therapy is a very useful therapy. When you know that how to use it, you can use that in multiple sessions in your clinic. We used to do that very regularly for all the TMJ and myofascial dysfunction patients in Mathura. I'm sure the postgraduates will remember that. Today we talk about neuromuscular dentistry. There's this typical branch which has come out of the routine dentistry, and it's an additional neuromuscular dental approach. When we know that the entire stomatognathic system, wherein the joints, the muscles of mastication, the accessory muscles of mastication, the gingiva, alveolar bone, and the proprioception of the teeth, they all play together for the joint health and the entire stomatognathic system. That's where the neuromuscular system dentistry takes a role. So it could be either way, the occlusion causing a problem or problem leading to an occlusal discrepancy. And always remember that the muscles of the head and neck are not just restricted there. There is a link to your posture, the cervical muscles, the lower back and upper back muscles up till the calf. There is a theory of chain of muscles concept. So it could be that the tooth is having a high point and then you may be getting a shoulder pain, or you have a cervical spondylitis and associated muscle dysfunction, which can cause the jaw to be functioning differently. This is the newer portion wherein you check with a T scan. If you do not have a T scan, at least an occlusogram, wherein you can check the bite of every patient, and then you can treat them. हाँ गरिमा, hello, time हो गया?
Yes, sir.
5 minutes, I'm finding it up. So TMJ arthrocentesis is again a non-invasive procedure. It can clear up the joint things. And today we plan everything with CBCTs. You know that CBCTs can help us in exactly locating the nerve before implant placement and after implant placement. Okay, and today's dentistry should be having all these things. You might have seen this instrument. If you have not seen this, this is another non-invasive technique for endoscopy in the salivary glands. The major salivary glands, the duct it can pass through. Even as a therapeutic method, you can use endoscopy. So we use 3D printing. I come back to the same case where I have done fibular transplantation with my surgeon. So that case, you had actually when done with the 3D printing, you could see exactly where is the lesion. And then the fibula was 3D printed plant. And then we took the fibula on the OT, and then we kept it as an anastomosis onto with the microvascular surgery. And then we placed the implants later, and I had shown you those. Okay, so that's exactly what an oral physician should be. You are not supposed to restrict yourself only to dental treatment, but then make sure that you go into the future with today artificial intelligence is coming into the picture for even diagnostic radiography. And that's it. Thank you. And all the best. And thank you for listening to me. Post lunch session, I'm sure it's a sleeping time for many. Thank you very much. I thank especially my dear student, Dr. Garima, and my good friend, Dr. Akshay, for giving this opportunity. Thanks to Indian Academy for Medicine and Radiology, wherein I have had a lot of stint for the last 30 years. the chairman of your college, principal Dr. Devi Charan Shetty, who is a very good friend, and your vice principal, and IT's Dental College, Ghaziabad, for your entire team, OMR, and all the faculty and the postgraduates to have shared the time with me. Thank you.
Thank you so much, sir. It was really an enlightening session. To be very true, it was just like a gist of whole oral medicine going into from page 1 to the last page of Burkitt's oral medicine at a glimpse. It's a beautiful cases, really nice representations. And I think the PGs must have learned a lot. It was really learning lesson for me also. A lot of things we miss out, and really good to hear you after a long time, sir. Thank you so much for your time. Thank you and for associating on a short notice. And I think we'll have a call on that.
Sorry, in fact, it should have been done 2 weeks back. Then we
Yeah.
could not connect because there was a major issue with the weather in Bangalore, and then we had not had any Wi-Fi there. And that was the issue technically. So I apologize for that part.
Nothing like that.
So whenever there is something nice and when there is a platform for scientific exchange, make sure that we all meet up.
Absolutely, sir. Absolutely.
Thank you.
Have a good day, sir. Thank you so much.